by Dr. Vishal KENIA. He'll be talking about biomechanics and refractive surgery. Over to Dr. Vishal.
Yeah. Good morning, everyone, and thank you for giving me an opportunity to talk on a novel topic of corneal biomechanics and refractive surgery. Cornea is not a piece of plastic. It is both viscous and elastic. So to understand the biomechanics, we have to understand the viscoelasticity. The role of corneal biomechanics in refractive surgery is especially in doubtful cases where you have a doubtful Belen embrasio, and an integrated Corvus pentacam helps you to screen whether this cornea is truly abnormal or not. Cornea which is biomechanically strong is suitable for refractive surgery, and as biomechanical changes precede topographic changes, you may have an absolutely normal pentacam, but still the biomechanics can be faltered and you may be caught on the wrong foot. So the first tool which came was the ORA, but the sensitivity specificity was low to differentiate keratoconus from normal corneas and even in keratoconus suspect. So this went out of vogue. Corvus ST uses a real-time corneal deformation data to analyze the corneal biomechanics. It records the corneal reaction to a defined 30 milliseconds air puff and an utilizing an ultra-high-speed Schimflug camera. This is used to optimize ectasia detection by a CBI composite dentice. Biomechanical analysis, comparative analysis can be done before and after LVC procedure, before and after cross-linking. It can also be used for glaucoma screening, and a biomechanically corrected IOP can be derived from a Corvus ST. A Corvus ST measurement display typically involves a Vincicura screening display, integrated display, and a comparative display. A Vincicura screening display gives you a composite index known as a Corvus biomechanical index, which is giving you the biomechanics of the cornea. Now this has 5 individual parameters based on the corneal thickness profile and the deformation parameter. Vincicura and Renato Ambrosio did a study where the CBI was found to be almost 98.4% specific and 100% sensitive in detecting keratoconus from normal corneas. So coming to what does a Corvus ST do? It typically gives an air puff and the corneal deformation is understood. The deformation amplitude ratio at 2 millimeters. So if you have a softer cornea, the deformation is much more quicker, deeper, and over a wider area. So this is captured by the Schimflug camera, and this is interpreted. Integrated radius is a similar parameter where the softer cornea deforms more rapidly over a wider area and more deeper, so the radius of curvature is steeper and the area subtended within is larger. Stiffness parameter SPA1 is the most sensitive and specific individual parameter to differentiate normal from the keratoconic corneas. The CBI LVC, this was an index developed to differentiate between normal, keratoconic, and post-LVC ectasias. So if you have an ectasia post-LASIK or any other LVC procedure, you can, from the CBI LVC, say for sure whether there is ectasia or not. So we did a small study, a Corvus biomechanical index 2 versus the degree of myopia. We did not find any association with the spherical equivalent. Ko et al. Did a study where the Corvus biomechanical index and severity of the keratoconus was seen. A strong association was seen between ARC and PRC. The most important composite index is the TBI, the tomographic biomechanical index. Now this already incorporates artificial intelligence. It uses a random forest classifier, and it helps us to distinguish subclinical keratoconus, and normal corneas. This is the most important index of the whole display. And if you see, compare it with the other index, this is the best. It is almost 99.6% more specific and sensitive compared to the bad D and the CBI. Now, the refractive surgical approach, if we divide it into 4 groups, if the normal tomography or biomechanics is there is no question you can do any refractive error. If the tomography and biomechanics are abnormal, so you don't do anything. So this scenario is pretty straight and clear. The scenario where the tomography is normal and the biomechanics are borderline, this is when you are in a dilemma, what to do. The biomechanics are borderline, whether to do a surface procedure, whether to do a lens-based phakic IOL, or to just observe the patient. So in such cases, we dwell more in detail. Either you can see the SPA1 parameters, or I had a chance to use the AIOC2022 from Narayan Netralaya group, and that would definitely throw in more insights in such borderline cases where it can give you a simulation post-surgery how the biocorneal stiffness is. If the tomography is abnormal and the biomechanics is normal, then most probably you should check the epithelial map or the quality of the scan, angle, kappa, etc. So in such cases, I would go ahead and do it or treat whatever the other causes, like an epithelial cause, we will have to treat the epithelial cause. So generally, I use the TBI as the guiding tool for deciding what kind of refractive surgery to do. The SSI, or the stress strain index, is an index which relates to the intrinsic material stiffness, and the normal value is 1. Softer cornea is less than 1, stiffer is more than 1. So stiffness is geometric plus intrinsic material stiffness. Here the SSI gives us the intrinsic material stiffness, which is independent of intraocular pressure and the corneal thickness. And it is basically used to compare pre and post procedures, the corneal stiffness. So again, we did a study, and it's under publication. The SSI was different in different grades of myopia. However, it was not significant. SSI was found to reduce with increase in myopia, and there was a negative association noted with the steep K. So this is the AIOC2022, which we had a chance to use. Uses the finite element simulation and artificial intelligence. It utilizes the data from the tomographer Corvus and the epithelial maps, and then a prediction tool. It gives you a simulation what the corneal stiffness would be and how it would be after the refractive surgery. So just to give you an example of one case, this is a 25-year-old male seeking refractive surgery. Here if you say the BAD-D is borderline, the CBI, TBI are abnormal. So in such a case, whether to do a phakic lens or a surface procedure, what would be the answer? The safest bet would be definitely, if the space permits, a phakic lens. But still, if you want to do a surface procedure, how would you go about? So we did AIOC2022 on this, and if you can see, the preoperative corneal stiffness is around 67.97, and in the other eye 66.51. So this gives you a flow chart where it shows a low risk of ectasia after surgery. So in such a case, either you can do a lens-based procedure, a phakic lens, or you can do a surface procedure with an extra procedure, a SMILE extra or a PRK extra. So to conclude, corneal biomechanical matrices can be used as an adjunct to tomography in refractive surgery screening. Corvus ST provides an edge over the conventional screening for refractive surgery, and this might help to make a better decision. Thank you so much.
Nice talk, Vishal. Just one query. Even in the example that you showed, there's some instances where the BAD-D is normal, the CBA is also normal. In your case, it was just in yellow, but the TBA is in far red. It was about 0.82. You did say that sometimes it's because of repeating the treatment, repeating the investigation, looking at angle kappa, etc. would help. Sometimes even those are normal. Such instances, it actually gets a little confusing because the two basic data which is supposed to give you the TBI, those are normal, but the TBI per se is abnormal. That was, even in the example you showed, that was the situation. How do you deal with that?
Sir, exactly. So dwelling more into the details of it, where it is a borderline biomechanics, like it's at 0.30 TBI, what next to do? So the question is that then you will require better tools like finite element modeling will help you to decide better. That is one. And if you don't have that, then you have to go in and see other biomechanical parameters, how they are behaving, and that would definitely help you. In such case scenario, if you're not very sure, either to wait or go in for an extra procedure or do a phakic IOS.